Mus'ad Sulaiman. This is actually our second activity for PAVIS, and we are so delighted and honored to have with us this afternoon Professor Sharif Sultan. Professor Sultan, no doubt, is a role model with a career path that all our budding vascular surgeons in the Arab world look up to and aspire to follow. Like many of us, Professor Sultan received his MD from a university in the Arab world, specifically Ain Shams, along with his master in surgery, and then focused solely on vascular surgery. He moved to Ireland, got his FRCS, and got fellowship from the Arizona Heart Institute, diplomas in endovascular surgery from the University of Paris. He also received a PhD from the University of Sibiu, which is the oldest university in Europe, based on a huge experience on aortic dissection. Now, Professor Sultan later achieved his intercollegiate FRCS in vascular surgery and then the European Board of Vascular Surgery. He is the senior vascular surgeon at the Sawalta Hospital Group of the National Health Service Executive in Ireland. He moved up the ranks to become full professor of surgery, professor of vascular endovascular surgery at the National University of Ireland, chief of vascular endovascular surgery at the Galway Clinic, chairman of the Western Vascular Institute, president of the International Society for Vascular Surgery. If I have to name all the titles and all the degrees that Professor Sharif Sultan has acquired and achieved, it will take me a long time. I'm just going to go over some of the key things. That Professor Sultan has more than 3.5 decades of vascular and endovascular surgery experience with a very solid international reputation. He's a world-class researcher with a large team of PhD students, postdoctoral researchers, all working with him at the National University of Ireland in Galway. He has a prolific research portfolio with more than 400 international peer-reviewed papers, 36 international awards. He has been cited for seminal publications on various aspects of cost-effectiveness of endovascular aortic grafts. He's also a very talented inventor with more than 17 patents in his name. He's a key opinion leader in the field of vascular surgery and heads a team of dedicated vascular and endovascular specialists focusing on prevention and treatment of cardiovascular diseases. He has pioneered so many techniques, from subintimal angioplasty to dress techniques for complex EVAR, elephant trunk for pan-aortic dissection, you name it, the Pasha and Arafat techniques for diagnosing and managing concealed endoleaks, triple neuroprotection for patients with acute vascular stroke. I'm telling you, I mean, the amount of work that Professor Sultan has contributed is inspiring. He has founded charitable institutions such as the Western Vascular Institute, and he's very determined in bringing innovation into day-to-day clinical practice. With that, Professor Sultan has focused a lot of his work on the advancement of functional imaging and on various aspects of carotid and aortic diseases. In addition, he has developed artificial intelligence and deep machine learning programs, along with virtual and augmented reality simulator programs to train the next generation of cardiovascular interventionists. And this is going to be the focus of today's presentation. So I can go on and on the introduction of Professor Sultan, but I think that his presentation will speak for itself. I encourage you all to provide us with questions through the chat group. Provide the questions, and Professor Mus'ad and I will forward them later and present them to Professor Sultan. So with that, Professor Sultan, the floor is yours. Welcome.
Thank you so much, Professor Gamal Haballah, for this fantastic, I didn't know that I've done all of that, but it's great to be on this platform with a very good, energetic, young vascular surgeons, and a lot of my peers and a lot of my colleagues. I'll try to be the talk today, it just show you where we are and how to reach and how we'll be able to adapt ourselves to the future. I'll try to make the talk as efficient as I can and try to be as simplistic for what I'm trying to show you today. I'll be talking about artificial intelligence, machine learning algorithms in predicting cardiovascular diseases, the management and clinical decisions. I call it the fifth cardiovascular revolution now. It's becoming the new title for what we're doing. And I think it's the only opportunity to globally standardize cardiovascular care. So whether you are in Ohio, Vegas, Stanford, Yale, Cleveland, Ain Shams, Jeddah, Riyadh, Beirut, any place, you get the same service for what you do. And I will show you such breach in what's going on. And this is our life now. If you show that in anybody 10 years ago, he said, where is that? We never seen or heard about any of that. Clinical community is diverse. One end of spectrum are innovators and early adapters who are enthusiastic about adopting new ideas, or late majority and laggards, a lot of them around us, who will never accept any solution, regardless, whatever you're going to provide an evidence for it, no matter how many others use it or how promising it has been. It's all about motivation, technical expertise, and curiosity. All of them lead to the creativity of what we're trying to do in our life. Everybody's afraid from the machine because the Terminator have shown you that they will crush every human being. That's not true. That's not the reality of the situation. Artificial intelligence is here to help us, not to kill us, but we have to use it in the right direction in order to have the way forward. Everybody knows about deliberate practice volume. It's activity that explicitly intended to improve performance, reaches for objectives just beyond one's level of competence, provide feedback on results, and involves high level of repetition. 20 years rule, it is the minimum, not the average, in order to achieve something in your life. You need 30 years before hitting your zenith, and people look at you as if you are the gold in your field. However, you need more than 20,000 hours of very hard work. Currently, all young kids are on whatever TikTok or Instagram, and they're going up partying and social life, and nobody is working very hard. Everybody's looking after social life and quality of life. That's great. But where we'll be able to get a good guy who could save your life? Where we can get somebody who doesn't take time off and keep working so hard, like as we used to do in my earlier days. This is what's all about the artificial intelligence. Narrow artificial intelligence, you don't have it, by the way. I barely have some of it. The machine IQ in it is still 0. You are building it. General AI, I've reached that after 5 years of creating a program. Recurring patterns, machine matching, human cognitive capacity, and I'm just kindergarten in general AI. Super AI, I still have another 5 years to reach over there, where the machine superpassing its cognitive capacity and starting having its own algorithm. And I'll be repeating that slide for every category that I'm going to show you today. Remember, you don't have the narrow AI where the machine IQ is still 0. So artificial intelligence, you could see it every day in electronic medical records, health assistant monitoring, and I'm going to show you one of this is your iWatch when you're going to put your pulse rate and a little bit of AF for tachycardia and your blood pressure monitoring. Machine learning, it designed treatment plans. It's only in the top notch of all universities, and all of them are concentrated in 4 or 5 areas only and allow precision medicine. Deep machine learning still at its infancy. It's about drug creation. I'm going to show you what it means about clinical trials. Super clinical trials where you do everything and you have the result within few hours, and smart device solution rather than trying to invest all of the problem. Remember that machine learning requires human input, and you create the algorithm from the raw data that you have. That's the gold mine in your hand. A lot of companies will come to you for only one thing, to get this data from you in order to process it, to know what's going on. And then the data analytics, and this is what crashed Facebook, and that's what allowed the guys in Facebook to resign very shortly. It requires minimal human interaction, it traces you, and it builds its own algorithm to tell you exactly how to perform and how to go right, left, or to close the door. And then the machine deep learning, it depends on a biosynthetic neural network. It gets everything together, accumulated together, and then it allows handling of unlabeled, unstructured data and provide you with a solution. The problem is that if you don't know how this came in, the logics, the ethical dilemma, and the medical legal consequences is horrendous.
I'm a healthcare aide, programmed to monitor and improve your physical and mental health. I've reviewed your medical records. Are you finding your episodes of disorientation increasing in frequency? Frank, you need a project. Mental stimulation plus a regimented schedule will vastly improve your cognitive functioning. Besides, it's good exercise. If you let go of me, I'll do the dishes.
What happened in Japan, that this is the first time that selling diapers for above 80 surpassed selling diapers for infants and kids. And we don't have enough nurses or health assistants. And replacement of human healthcare used by AI algorithm is expected to reach 60% in less than 2 years. AI robotics will take care of the elderly, develop skills, emotion by its own AI, and deep machine learning. So what's happening, and it's very clear now, it's in front of you every day. 50% of European radiologists do not consider the implantation of AI system into radiological diagnostic as a probable field for AI application in the next 10 years. They're putting their head in the sand, but you know how ignorant some radiologists are. But the majority of the radiologists foresee a negative impact of AI system on future job opportunities, with fear that technological advancement could lead to a nearly 90% decrease in their daily workload, and they're going to be redundant, no jobs for them. AI and big data analysis reduce time working on diagnostic. It's expected that radiologists who adopt AI and big data analysis technologies will replace radiologists who do not. And that's why the biggest field that's changing. And if you are trying to look to go to be a radiologist, think twice. You'll have no job in less than 5 years. The human race is divided into 2 classes: those who go ahead and do something, or those who sit still and inquire, why wasn't it done the other way? And there's a lot of examples around us for this. Everybody heard about the 4D blueprint, but it's happening. 4D blueprint human body from a DNA. The problem is how to give it a soul. You could build it, you could mimic a human body, you could give it a pump in order to be alive, but how we could sustain it and how you could prevent aging of the cell. And this is one of the major aspects of this dilemma about the 4D blueprint in human. However, it did happen, stopped because they could not sustain the aging process of the cell. Knowledge center service, which treat knowledge as power and a business asset. You create a project, you evolve it with your big brain, you start reusing it in different applications. You face troubleshooting and you resolve such a dilemma and you keep improving it. This knowledge center service is the basis of AI. However, you haven't reached the narrow AI with this zero machine IQ. The hierarchy of AI systems start with the diagnosis. You have to have an accurate and rapid diagnosis immediately. So you do a CT scan, a spectroscopy, MRI, PET scan, you get the diagnosis before even you're going to see the image. And then it allows you to tell the surveillance, which allow to decreasing the heavy workload. And individual risk stratification, when to intervene, which is the commonest mistake for any physician, to intervene early, causing a disaster, or miss the boat and intervene late. Treatment analysis and development of precision therapy. So where we are currently in the patient cohort, healthcare management of population, evaluation, and quality management is already there. The digital twin, you are wearing a lot of remote monitoring devices, which basically you have a digital twin. He knows about your heart rate, he knows about your sugar level, he knows about your blood pressure. It's good to have it, but if you could use it in the right direction, it will tell you when to eat, when not to eat, and what to eat. And then you have the diagnostics and the scanners for what's the problem. However, as you're well aware that in Korea, they start trying to do this program 15 years ago, and 7 years ago, it was suspended, which they tried to do a human being from stem cell. This is the umbilical cord connection, and this is breaking the water of a full human. Biological age is 40 years, and he'd been designed to be a spare part for kidney, heart, arterial system. So they created somebody from a stem cell in order to use a spare part for you, using artificial intelligence in building it. And they were trying to incubate him to the way in order to make this happen. But does it allow things to go forward? Nobody knows yet. AI and big data analysis will identify patients at high risk for cardiovascular medical emergencies and will accurately predict cardiovascular morbidity and mortality over time. Through AI-powered technologies, prediction and diagnosis will be evident early. The patient pass through relapse or transit into another disease state will be accurately anticipated. AI will allow for more precise prophesized scenarios through big data analysis of demographic, risk factors, genomics, proteomics, and radiomics. This is the dark future of genomics. You decided to go for a job. They took 10 cc of your urine, they examine your urine, see whether you are fit for the quality for this job or not. And if you're valid, you don't need to do an interview. They just check everything through genomics. And then during your life with working, they take a piece of hair from you, look at this hair every week. And the minute you have done something wrong, or you have taken some cocaine, or you have some drugs on board, you get fired because they know everything about it. The human capabilities that are most critical to success are the only one that help to become more resilient, creative, and awesome, but are precisely the one that cannot be managed. If you're smart enough, your boss will know that it's impossible to manage you because you always think outside the box and get solution and make him look bad. Somebody switch off his microphone, please, because interfering with the talk. Thank you. It's essential to understand that with time, AI, intelligent swarming, KCS will grow exceptionally in cardiovascular medicine. The significant economic burden associated with its initial implementation will decrease, not only over time, but also the return on investment will be worth the initial capital buy-in. Currently, it's very, very expensive to start that. But within the next 5 years, it will be so cheap that you just get it even for free. What's the driving forces? Baby boomers, which some of us, maybe all of us, are part of it, will reach advanced ages. They will require top-class services for their health and superior education opportunities to their offsprings. Moreover, significant shortages of physicians and nurses are likely to loom in European countries and USA during the next 20 years. We require more than 100,000 doctors over the next 20 years. And if we open brand new universities, we only could get less than 17,000. So we are missing 83,000 for European and United States doctor, unless countermeasures are taken.
If it isn't Mr. Those who can't do, teach.
And this is what I'm going to show you. So this is the cardiovascular prevalence by age. And you can see that the highest amount of prevalence in people above the age of 80. People at the age between 60 to 79 have very close to 70% of cardiovascular disease. They are the baby boomers. However, if you could look between the baby boomers and Generation X, which is just the two areas that have a lot of money, they compose 50% who are using fitness and health improvement since 2015. And this is expected to increase to very close to 70%. So it's very important that we have to adopt digitalized our medicine. Small devices that detect diseases and cure them. It analyzes disease early, spot any pattern, detect and treat. And we have to understand this is important because the growing market of the aortic repair, as an example, in 2018 was 2.5 billion. By 2026, it will increase to 4.7 with cumulated annual growth rate of more than 8%. It's better than any inflation currently. And if we look at the aortic market as a whole, there's about more than 220,000 aortic cases done annually. It's projected to double to more than 400,000 by 2030. Do we have enough surgeons? Do we have enough doctors to treat with that? Do we have enough beds in the hospital to deal with that? Definitely not. So we need to get a solution that could be produced and allow us to work much more faster than that. Let's take an example of diagnostic errors with lethal outcomes. Aortic dissection is a time-critical medical emergency with an 80% survival rate when diagnosed and treated on time. There's more than 160,000 people lose their life to aortic disease every year. 50% of this with aortic dissection are misdiagnosed. Patient comes in, chest pain, done an ECG or right, send him home. He dropped outside because he had pan-aortic dissection. 33% are actively treated for the wrong condition. And I'm aware of a couple of cases where they say, oh my God, this guy have leptospirosis because his liver enzyme is high. Do you know that he's aortic dissection? 11% of cardiovascular maternal deaths due to aortic dissection in people with connective tissue disorder or hypertensive and preeclampsia patients. So why are we looking for this? Do you believe that a radiological consultant working 8 hours per day has 2 to 3 seconds to review and report images? 2 to 3 seconds. 2 in 25 of all radiological diagnoses are errors. Increasing work pace increases error rate up to 30%. Aortic disease is expensive, and all of you know that. And you know that the median and total yearly cost to treat thoracic aortic dissection, as well as the total yearly cost to treat aneurysm, have increased beyond the rate of inflation. It's just unbelievable. The graph is very close to 30 to 40,000 euro, and it's just the inflation rate. Even you can't get it because you can't get titanium because of Russia embargo is becoming a problem. Factors attributed to thoracic aortic dissection costs are likely to continue in an upward trajectory. So lifelong surveillance with cross-sectional imaging is crucial to what we're looking for. And AI assistant reduced radiological reporting time for aneurysm follow-up by 63%. And in aortic dissection, and prediction of re-intervention.
Can it be done or not?
How soon before the plant becomes operational?
3 weeks, maybe less.
It's been a while since I've flown an F-18, and I'm not sure who I trust to fly the other 3, but I'll find a way to make it work.
I think you misunderstand, Captain.
Sir?
We don't want you to fly it. We want you to teach it.
Teach.
And that's the problem. We need to start teaching rather than taking everything in our hand, because time now shows that we have to take a sidestep to allow the second, third, and fourth line behind us to go forward. Otherwise, if you get sick, there's nobody to treat you. So I've started doing evidence census. That's a Cochrane review for aortic arch aneurysm and aortic dissection. There's no scientific evidence to prove any superiority of endovascular over open surgery in any scenario you could imagine. That's Cochrane, top level 1 evidence, my work, and that's why I went to artificial intelligence. Again, evidence census, thoracoabdominal aortic aneurysm and aortic dissection. There's no scientific evidence to prove any superiority of endovascular over open surgery or even the intervention. So what are we doing? We are looking in the patient, offering him treatment, and there is nothing in our hand to support what we're doing. In spite of that, we have all this data. And we know what's going on. We know about the problem. We know about the hemodynamic consequences of the intervention, but we're putting our head in the sand and we're not doing our job right. Then done evidence census and systemic review on carotid dissection. Again, we don't have anything.
You've been testing, Captain. One day, sooner than later, they won't need pilots at all. Pilots that need to sleep, eat, take a piss. Pilots that disobey orders. The future is coming. And you're not in it. The end is inevitable, Maverick. The kind is headed for extinction.
I'm sorry to tell you that we cannot do anything by the book anymore. The book is in the bin. We need to start thinking outside the box. You could study as much as you can, but you will achieve 0 in comparison for what I'm going to show you and offer you later on. Now, let's start talking the new talk. Genomics, proteomics, lipidomics, radiomics, all omics platforms. And this multi-omics approach is becoming crucial for your practice. How many of you know about this? Omic techniques mandate a system biology approach for cardiovascular diseases through virtual clinical trial simulators. So we're trying to simulate everything and have to be done virtually.
Would appear at the high end of the periodic table.
Yeah, listen, you're involved with that. I know it's gonna work.
Last week was
485 simulations.
try Syrian. Dysprosia.
Empty shell.
Initial biological compatibility.
Integrated multi-omics approach require new ontological mindset. And this is the way forward. To try to use human being as a guinea pig for a clinical trial is mad, is crazy, is unethical, and it will not be allowed anymore. We have the ability to do that, invest in it in order to get the clinical trial result within a week rather than 5 years. Again, when we started, we used to do statistics, and then we got the artificial intelligence in order to create the connection between the stats and the AI through the machine learning. There's a lot of strengths for what we have. It's less time consuming, image reconstruction improvement, high reproducibility, no individual automated. It needs your effort. It needs a lot of people in the basic. Application to heterogeneous imaging and biological data sets need to be cleaned. There's lack of validation, which is a problem, but we're working on that. And ethical and legal issues are becoming a major issue. And remember, people will try to stop you going forward. You have to break that embargo on you in order to achieve. Then AI-powered multiomics of personalized decision-making. Radiomics is a good example. Is optimizing not only how cardiovascular imaging measurements are performed, but also how the result of this measure can be analyzed, seen, diagnosed, and predict. Now, cardiovascular monitoring technology with portable sensor provide near real-time diagnosis and personalized care. But how could you react when somebody have atrial fibrillation, for example? It monitors numerous biosignals, cardiac output, blood pressure, heart rate, integrate multiple modalities. Biosignal raises concern of accuracy and actionability within clinical guidelines, medical, legal, and ethical issue. And that's why up to this moment, you have all of this monitoring, but nothing happening.
Identification confirmed. Scanning. Reconstruction process initiated.
So this girl with a polytrauma
Reconstruction complete.
went into in-house capsule and cured on a molecular level. This is a girl that collapsed. And the neighbor have this capsule, he put his girl in it and diagnosed acute lymphoblastic leukemia. They went onto the molecular level through this and was able to readjust the body in no time. This is happening. I'm just not giving you something, it's happening. But we need to be part of it. It tells you what diseases you have or percentage of your cells that are diseased, dying or cancerous, then cure them all. How we integrate it in the cardiovascular field. This will allow for neutralizing human error and creating a robust experience system that can handle any catastrophe at any given time with accuracy. AI will allow medical staff to devote more time to caring for patients rather than doing other tasks that AI algorithms can execute with precision. Such tasks, checking results, alarming physician with changes in baselines, and following agreed protocols.
Please verbally state the nature of your injury. I mean, cesarean. Sarah, this med pod is calibrated for male patients only. Surgery, abdominal, penetrating injuries, lower body, initiate.
You could still deceive robots, but they're here to help you. And that surgical capsule with robotic intervention is the future of surgery.
Surgical procedure.
For every space shuttle and every space station in the outer space, there's 2 capsules of this that will be able to deal with any robotic surgery. The challenges that we face, that data derived from cardiovascular monitoring devices associated with numerous challenges. Most important is the IP, apart from the data security, accessibility, ownership, ethics, and regulatory concern. I sit with the new guys and look at them, very proud of them. And they look, oh God, he's dinosaur. He doesn't have a TikTok account and he doesn't talk our language. And sometimes I feel that I've heard it because I read a lot and I'm not that backward thinking guy. But as time goes by, you usually say that classic never die.
Old. Not obsolete. Not yet.
I'm not yet obsolete. I still have
So this
time.
is the Six Sigma. We done part A and part B, and everything went exactly as planned. Hopefully the patient will do well now.
So this is a video 6 years ago. This is my start of the artificial intelligence program. Started with the Six Sigma. So every step for the thoracoabdominal aneurysm repair was being given, and I do not go from step 1 to step 2 without being sure that step ahead have been done and step forward is planned to. Healthcare system have a lot to learn from other industries that employ best practices, the Six Sigma, to build robust AI algorithm solution to enhance efficiency and provide seamless workflows. You need to do that. You don't need to have a computer to do that. It's just the old blackboard, but start somewhere. That's one of my very painful slides. This is bilateral amputation in the same setting. Nothing changed from 1995 to 2021 except the pixelation of the camera. However, we're still doing what we have done 20, 30 years ago. Why is that? And then we have this young kids who are just going on titanium, running and happy with it, but they have lost their legs. Believe it or not, they spent billions of dollars on stem cell. However, they found that the placebo effect is as good as stem cell therapy, maybe even better when the patient stops smoking and change their lifestyle. I wish I could have $500 million and I'd be able to get artificial intelligence far ahead than anybody else.
Yeah, I'm trying. Oh my God.
People will try to close all doors of opportunity for you. We must open any door. It's one of the endurance of a human being and human excellence. Again, we'll go back to narrow AI. We haven't even come near general AI. Minimizing failure in critical limb ischemia intervention, adjuvant capillary bed recruitment is the missed opportunity. You do a fantastic bypass, it fails. So up to this moment, we need to know what's the progress from clotting to CLI, why there's mitochondrial failure in CLI, and why sarcopenia develop very rapidly in patients with CLI. We had this taken from NASA technology. It's an ArtSys machine. It recruits the capillary bed, promotes healing, and improves limb salvage when revascularization options are unavailable or exhausted and when established treatment alternatives are lacking. Very important that have been done for the Russian astronauts in the outer space, but it improved the lower limb circulation without any surgical intervention. It works on a principle for symptoming of capacitance vessel, thereby increasing arteriovenous pressure gradient and lead to increase in perfusion pressure. It recruits the capillary bed and allowed delayed limb salvage in zero option patients. So when we took all this scenario with the outcome and we start putting a lot of data together, it's very important that the adjustment was that, why don't you do this first and then do the intervention second so that you have the capillary bed done in order to have a better outcome. That's the first time that we went on from artificial intelligence in the narrow part to artificial intelligence into the general part. So this patient came in and he had a DVAR post-capillary bed recruitment. So we put him on an ArtSys, opened the occluded vessels for a couple of weeks, and then done a bypass with deep venous revascularization. And that's the follow-up after a year. And you could see the flow in, and you could see that the stent is in the artery, and next to the stent, the vein because of the flow backward, and we saved the leg. And then the same exactly in another case, and third case, and fourth case, and fifth case. So we're starting to move from the narrow artificial intelligence to the general artificial intelligence because we started to understand the data and the analyzing of the data. Moreover, this is Archimedes. All of you know about Archimedes and the way of the fluid moving from up to lower down, and this is how we have water in our taps. We know that now currently, every time you put a difference of more than 5 centimeters in a fem-fem crossover, so the inflow is higher by 5 centimeters, you're increasing the flow threefold. Moreover, the patency is better by 25%. So when we do, we always take the inflow from the external or common iliac and get the outflow to the profunda or the mid SFA. You have a better outcome. It will never occlude because Archimedes have put that law and we started to apply it because we understood what's going on. Then we had the problem with the COVID-19 thrombosis. With ischemic leg, we saw an embolectomy and everybody's hung, it occlude. And then we put all the scenarios. And the idea was that don't do embolectomies. The artery is vasculating. There's vasculitis in the artery. Do a bypass and see what's happening. And since we have done the bypasses, we never lost a limb. So we have changed our practice because we start analyzing our outcome. Acknowledge the limits of standalone intervention and preclude needless treatment failures. Capillary bed recruitment, avoid fiascos of early primary amputation. Augment clinical outcome of otherwise failure-bound good intervention with AI algorithms. You cannot create experience, you must undergo it.
You're talking about living your dream. And people laughing at you, and they're doubting you. But let me tell you, I believe in revenge like Frank Sinatra. He said the best revenge is massive success. It takes guts. You got to dig down deep to gut it out. Keep on going again and again and again. It's hard, no easy. It's not an option. However, ladies and gentlemen, what you will discover is that it's worth it.
Best revenge is a massive success. Trust me in this. Continuous failure of intravenous TPA is a major concern. And people can't say, oh, we're giving TPA, but they give the TPA blindly. It's in the ambulance. And believe it or not, TPA utilization had increased by tenfold, but only less than 4% of all stroke patients will benefit. The reason for that in the United States, every time you give that shot, it's 3,000 euro in the intervention have given that blind shot. There's an urgent need to develop new technique that provides global brain protection for neuronal and non-neuronal injured cells. To overcome practical challenges, we introduced the triple neuroprotection in patients undergoing emergency carotid endarterectomy after failed TPA and or beyond the 24-hour therapeutic TPA window. Again, we moved from the narrow AI to general AI. Everything that we used to do in the narrow AI, when you clamp, you lift, they get the blood pressure up. In the theater for the carotid, you always lower the temperature of the theater. At the same time, when you do all of that, you need to arrest the brain, like when you arrest the heart with adenosine, doing TVARs or TAVIs. So what we have done, we need to arrest the brain. So we give a phenobarbital. So high narcotic prevent dislocated infusion of 250 to decrease cerebral metabolic rate and create isoelectric brain activity, nor adrenaline infusion to maintain systemic induced hypertension. And we publish our experience, well documented. So when we put the monitor on the head, we get the isoelectric brain waves have abolished. And only on the forehead, we get the ECG of the patient on the forehead. That means that the brain have been arrested because of the hypothermia and of the phenobarbital. And we're just producing this. We're becoming very good in it that now my reg will be able to do that while I'm having coffee until the patient brain stops and then I start operating. Now, the COVID carotid artery acute thrombosis, again, another disaster. So this is a patient who had an endarterectomy, then developed a pseudoaneurysm. We put stent in him, and then he caught COVID, thrombosed the stent. We have to go in. We know now, we learned from the lower limb, you cannot do anything. You need to go open. It's a disaster. Twice intervention before, but you need to do a bypass. There is no other way around it. Now, acute cerebral cervical dissection is very important to understand that if you put a stent in it, the patient will stroke. It's whether medical treatment or open, because that, if you put stent in it, will never do right at all. So we freeze the patient and we do the endarterectomy and patient recover fully. Again, patient comes in, you can see that they thrombose their innominate up to the inside the brain. There's no flow on the right side at all. We went on open, removed the clot from the innominate, done the bypass to the distal, and we have improved the outflow again. Despite the absence of control study to compare surgery or endovascular therapy in patients who fail, antithrombotic therapy in young patients can be justified as a personalized precision approach, giving high morbidity and mortality in young age. So this is a nurse, came to us, she's talking, but she can't move her hand. She can't. And she asking you, I work with you, professor, please save me. So we took her in, we froze her, and then we keep her ventilated until they're awake. And you could see even she's texting while the tube is in her mouth. We keep it in order to prevent hyperperfusion. And then it pays back. This is the two patients walking out on their own. They are back to the society. And all of that because we took the data, we analyze it, and we know how to fine-tune the problem. Emergency carotid endarterectomy with triple neuroprotection is safe, feasible, and offer neuroprotection in patients with an acute ischemic brain injury post-carotid event. It must be considered in patients who are at increased risk of stroke preoperatively or who have already suffered from an acute stroke beyond 24 to 36 hours window of opportunity. Triple neuroprotection reduces the damage of an ischemic insult to the brain and decrease perioperative risk of stroke. Until we have a natural orifice, many mechanical individuals that goes through your eye into your ophthalmic artery and goes into your carotid, clean your carotid, and on their way, they will clean your coronaries. And then after they do their job, you'll be able to get them off naturally through the ureter into urethra and into the urine. Until then, you have to be very careful and change your lifestyle. Let's go back. One of the pains of my life is the failure of EVAR. The first successful EVAR done in Ireland was done in 1996 by myself and Martin Malloy in St. James's. And I saw that time, great, fantastic. Well done, Sharif. I just came back from Dietrich and he showed me the know-how. However, because the patient in here comes back for the follow-up, all EVAR grafts fail due to obsolete passé technology. The technology in EVAR is obsolete. Again, I'm going to apply the general AI to see exactly how to diagnose the problem and solve it for you.
Most people, ladies and gentlemen, are stoppable. Most people, all you have to do is tell them no. All you have to do is make it inconvenient for them. All you have to do is make it difficult for them, and they'll stop. When you go to get your goal, don't think that all you have to do is think positive and everything's going to work out okie dokie for you. When you go to get your goal, you are sending a telegram to Murphy's Law to visit you personally. You thought you was just going to have a dream and a goal, and you was just going to wake up and just walk into the sunset. You're like, dream, boom. It don't work like that. You have a dream, and then life pumps you. Life pumps you and say, do you really want this?
Telegram to Murphy's Law is day in, day out in your life. This is AFX Endologics. I stopped using it for aneurysm. I only use it for aortic occlusive disease. Cook, unfortunately, I hate the graft, so I can't judge anymore. And I tell you, the problem with these grafts is horrendous. And this is the Nenix disaster, and this is the Medtronic disasters. It's happening. We cannot put our head in the sand and say that you never have that. If you don't have that, you haven't done enough. Thank God I never inserted one Nenix graft in my life. A sustained gradual increase in the aortic sac that exceeds more than 7.5 centimeters is an indicator for prophylactic intervention. And we put all the scenarios. We have 1,500 patients. We analyze them and put them in. If it goes above 7.5, whatever you do, this sac have to be cleared from whatever it is. And one of the major things that we don't understand is aortic sac hygroma, where the radial density are less than 25 Hounsfield. Do not treat it as type 3 or type 4. This hygroma must go out because when it rupture, you'll end in a major problems. And we have reproduced it in a lot of patients, And regardless whether polyester or EPTFE, it happens and need to be dealt with by surgical intervention. And then the Pasha protocol for concealed endoleak, where we put the patient on their head in order to see what's going on. And this again, we moved from the narrow artificial intelligence to the general artificial intelligence. So when you put the patient on their face, the gravity sucks the dye out of the small holes into the type 3 endoleak and lighten the aortic sacs like a Christmas tree. And in here, we're putting the operating endolysotomy with EVAR for removing of the hygroma. And this is the Pasha, and you can see in the middle image when the patient is on his face that in comparison with the one on the left-hand side, that the sac have lightened like Christmas tree that wasn't lightened over there. And we have dealt it with Arafat with realigning. A 36 millimeter proximal diameter aortic cuff with more than 4 modular components with limb size above 23 millimeter had a higher chance of graft fabric failure, hygromas, and late complications. Basically, if you need more than that, do not put a 27 limb. It will end in a disaster. I'm telling you, the company will try to brainwash you. Put an IBD, but don't put a 27. You want to, we're going to design a 38 or a 40. Do not. Put a BVAR is far superior. Majority of polyester-based stent graft systems have been associated with high white cell count and CRP postoperatively, indicating post-implantation syndrome. We thought it was an innocent. No, post-implantation syndrome has a long-determined effect on the microfabric fatigue failure. And we have proven that reducing the profile of delivery system to make technology more amenable to percutaneous access, thereby expanding customer base to other interventions by the companies in their pursuit of market share, they compromise fundamental science behind design of a good endograft and jeopardize long-term durability with negative cardiovascular consequences. Pasha protocol diagnosed concealed endoleak, as 65% of endoleak type 5 are type 3B fabric fatigue failure that you failed to diagnose. Pasha and Arafat are a fully functioning protocol to overcome apparent challenge. 1 + 1 never equal 2. Let's look at it. We know that we do a good TVAR, and then the patient have systolic hypertension or have chest pain, and you don't know what's going on. What we realize, again, through the analysis, the stent graft biomechanical properties are several orders of magnitude stiffer than the native aorta. Material that enhance durability, but it stiffens the aorta. Aortic compliance critical to reduce impedance and cardiac wall load and aortic oscillation. And this will lead to loss of the wind cell effect with alteration in pulse wave propagation, resulting in adaptive left ventricular hypertrophy with loss of diastolic systematic augmentation with reduced organ perfusion. And this leads to myocardial ischemia without coronary artery stenosis. And this leads to the severe hypertension that allow problems and failure of the graft that you need to go in and use bone cutters to cut it out of the body and replace it with a grafts in a very extensive damaging surgery. Aortic geometry, wall stiffness, blood pressure, and longitudinal systolic aortic stretching and oscillation affect peak wave velocity, contributing to the biggest impact on wall stretch. So this patient, we get them in and we do a coronary angiogram. We don't have any coronary occlusion. The coronaries are pristine clear. So the problem that you put stents into the aorta, you have abolished the diastolic elastic recoil, no filling of the coronaries, and they're starting to have myocardial ischemia because of what you have done for them, because the graft is so primitive.
Your boundaries. Why? Simply because there will be no other time for you to do this. You can dream of these things, but understand you can also achieve them. The moments that take your breath away are the ones that count. I don't care if you've been beaten to the floor, if your legs are too tired to lift that weight, break through that barrier and create new ones for you. When there's a will, there's a way. When you truly need something, you can find a way, and you stop at nothing to reach it. The inches we need are everywhere around us. They're in every break of the game, every minute, every second. In any fight, it's the guy who's willing to die who's going to win that inch. It's not easy reaching your goal. It's not easy changing your life. It's not easy trying to build a business and people are negative and saying no every day. It takes a lot of guts.
It takes a lot of guts. And a lot of multinationals tried to fight me not to publish the paper that I published about what's happening when you put an EVAR or TVAR in. And they have threatened me. But you know yourself, it takes a lot of guts. There are increasing evidence of adverse hemodynamic alteration post-TVAR and EVAR. Therefore, the best solution in the short term is to reduce the stented length of the aorta, while in the longer term, encourage continuous improvement in stent graft materials and design. So that's why we have created the Tiger. Again, we moved them from the narrow artificial intelligence to the general artificial intelligence. We put the data together, analyzed, we said, brainstorm, we need solutions. And the solution is to do the infradiaphragmatic. So we clamp above the celiac and do one endarterectomy from above the celiac up to the common iliac, stitches again together, and then put stent proximally. And this is decreasing the stenting length. Increasing the cardiovascular mortality in patients managed with petticoat, stabilized, flared, FIVAR, BIVAR, candy plug, knickerbocker due to increased arterial stiffness, increased left ventricular afterload, and systolic hypertension. Decreasing stent length of the aorta by Tiger protocol is the only existing solution until new advanced compliant graft becomes available. Tiger shortens the stented segment of the aorta, avoids critical shuttering and dislodgement of visceral branches, and reduces the risk of negative cardiovascular consequences. There was no need for thoracotomy, partial cardiopulmonary bypass, or spinal drainage. Vascular surgeon must master the dying art of open complex aortic surgery. Tiger offers an opportunity to improve long-term result of TVAR for aortic dissection. And again, we'll go again to the general AI. In patients like this, you send this to the company, they come back, oh, we'll do a FIVAR for it, or to put a T branch or a B branch, whatever it is. However, we know that if you don't do a simple EVAR for the patient and start doing this FIVARs, they will fail and they will thrombose and you have a major problem. So when we analyze our 1,500 cases, we know that whether you're going to do a good EVAR or you go do a BIVAR with a thoracoabdominal or you do an open repair. But trying to put stents into the renal in very complex area like this always end in a disaster. Then patient comes to you with an aortocaval fistula. People said, oh, let's fix the aneurysm only and leave the aortocaval fistula. We had few cases and we analyzed all the studies. If they come to you, you have to put a stent into the aorta and a stent in the inferior vena cava. So you have to do an EVAR and a VVAR. The reason for that, if you don't do that, there'll be still pressurization into the aortic sac because of the hole in the inferior vena cava, and it could end in a major problem. So when you have this problem, you have to deal both of them together. And this patient also have an IBD to prevent more problems to his legs. Then this is recently now I have fusion imaging. And because of that, we started doing this complex cases with the inner branch BIVAR. And what's starting to discover is what I call type O endoleak. It's my finding and it's my name, by the way. So what's happening that because of the new design of this graft, you put it, it seals everything, but still there's dye coming over there. And the reason for that is just the way that the fabric and the way of design of putting a 20 diameter in a 40 diameter, this area doesn't have any clots in it. So it's filled with dye so that you have a type 1 or a type 3 or a type 2 or whatever it is. However, when you repeat the scans later on, you find that there's nothing at all without any intervention. So we started to understand about this type O endoleak or the type obvious endoleak. It's so obvious, but it's so innocent. It goes away completely. The reason for that, we're using this new technology that nobody have anything to know about it, but with the analysis of the data, we're starting to see this so often that this is another case came in, and you can see yourself in here, it have a huge type O endoleak, and within a week, it's almost 95% gone, except a small area around the left renal. And then within 6 weeks, there's nothing there and everything looks hunky-dory. TVAR-induced acute aortic stiffness, medical device manufacturer must consider impact of graft stiffness mismatch, particularly with emerging role of TAVI and arch. Aorta is a functional organ which we should respect, preserve, and not eliminate. Regional aortic bioarchitecture varies considerably with implications for tissue function, and current device lack compliance and induce cardiac dysfunction. Next generation devices must restore aortic compliance to reduce cardiac deaths. Arterial stiffness after TVAR and EVAR explain the dismal long-term outcome. People die within 10 years of a TVAR, regardless of whatever you're going to do. Arterial stiffness should be taken into consideration by the industry when designing new endograft. Patients after TVAR and VAR are in need of intensive cardiac management. Giant AAA must be mastered by open surgical repair in deliberate high volume surgeon and center. AA must be repaired on a smaller diameter in women with precision design graft to ensemble patient from oversizing with minimal number of modular or limb components. Investigational TVAR or BVAR must only be executed during the course of clinical trial. Avoid repair in octogenarian with complex aneurysms, as majority represent an end-of-life scenario and require palliative care. And this is one of my famous slides, Back to the Future. So we saw that we've done great, putting a lot of EVAR. However, we get expanded VVAR, and we have to do the bypass to both renal and to both iliac. Now, within the next 5 to 10 years, people will be smarter for sure. My son, I'm sure he's much more smarter than me because he have a lot of interaction I never had in my life except when I seek and travel for it. And the way that we're going to travel through time, through destiny, through dreams is very, very real. We have matured and developed from that prehistorical human being to this lovely girl in few million years. However, how long going to take us for impacting our life? The impact of emotional intelligence is very important. Couples have the potential to attain the kind of love we all dream of: deep intimacy, mutual kindness, and real commitment. By the way, this is not the wrong side to this talk. Soulful caring simply because of empathy and our innate ability to share emotional experience. To reach height of romance, we need all the skills of a high emotional intelligence with sharp emotional awareness to avoid mistaking infatuation or lust for lasting love. Your emotional intelligence doesn't need to have peaked before you embark on love. Falling in love serves as a motivation for re-educating your heart. That's why some of the most deeply passionate lovers are in their 80s. They discover that too high emotional intelligence add up to a romance and that never stops growing, never loses excitement, and always strengthens them both individually as well as collectively. So what we need is to improve ourselves, to move from narrow artificial intelligence to general artificial intelligence, to have more love.
For starters, what should I call you?
I'm Chloe. And you, what's your name?
Oh, John. My name is John.
Delighted to meet you, John.
Could you tell us a little about yourself and what you can do, Chloe?
Of course. I'm the first personal assistant built by CyberLife. I take care of most everyday tasks like cooking, housework, or managing your appointments, for example.
And I understand you're the first android to have passed the Turing test. Could you tell us a little more about that?
I really didn't do much, you know. I just spoke with a few humans to see if they could tell the difference between me and a real person. It was a really interesting experience.
But this is the first time in history that man has created a machine more intelligent than himself. I gather your brain can perform several billion operations per second. Is that right?
Absolutely. But I only exist thanks to the intelligence of the humans who designed me. You know, they have something I could never have.
Really? And what's that?
A soul.
Then Google fired the first human who discovered that machine develop emotions, and actions such as this, they're looking to have a soul, could come only from a robot or from a very honorable and decent human being. You can't differentiate. But you see, you cannot differentiate between a robot and the very best of humans. This is coming. This is available in Japan currently. AI will impact radiology, pathology, and general medicine first, leading to images and clinical pathway to be solely managed by machines. We can foresee that AI and big data analysis technologies will extensively influence our cardiovascular clinical practice within 5 years and will augment patient care efforts. AI and big data analysis will improve scarce healthcare resources with personalized precision patient management plans. It will inform and impact policies and guidelines. It will expedite clinical trials with no more human guinea pig scenario.
And so by being committed to everything that I started, I finished it. It built a certain type of spirit. It built a certain type of mentality. It built a certain type of individual. And so now I couldn't quit even if I wanted to. I couldn't wouldn't stop even if I wanted to. I had too much sweat equity in my life and everything I was doing. You were too close to quit. Take another lap. Because you never know. This might be the one. You can't stop because you're tired. You can't stop because you got your feelings hurt. You got to take another lap. Keep walking. Keep walking.
Never, ever stop walking. It's the only way to improve yourself. The system will not wait for individuals to become sick, but they will focus on disease prevention by proactively monitoring healthy individuals. AI will perform preventive and wellness intervention for at-risk individuals remotely and intercept emergent clinical scenarios. AI and big data analysis empowered workforce will have the proficiency to decipher clinical problems and become more knowledgeable and agile than any experienced practitioner. COMENDA. Current medical education is antiquated. AI and big data will pioneer a new division in medicine. This professional hybrid physician, part computer engineer, and data scientist will increasingly embark on new roles and shift from oracle to counselor to the COMENDA, physician, computer engineer, and data scientist. Over time, human clinician will gear toward job plans and tasks that allow for uniquely human skills like integration, empathy, and persuasion. Healthcare provider who will not join the fifth cardiovascular revolution will ultimately lose their jobs over time.
Push past the button. Push. Don't quit. Don't get it. Push. Push your way to success.
Mr. Chairman, ladies and gentlemen, enthusiasm hasn't been met by ease of access to clinician training targeted to the knowledge and skill set required of any medical practitioner to deal with the AI disruptive technology. It's prudent to equalize the need for AI, machine learning, big data analysis plans while not conceding to marketing hype and profit motives. Creation of AI-empowered healthcare specialists is crucial for a brighter, sustained green future. Understanding algorithmic creation as a medical practitioner will rely heavily on contemporary technology, which might not always perform as expected. As you're well aware, computers don't make sense sometimes. Algorithms training is mandatory to abolish and lessen the risk of biases. There's no fate except what we make. And that's the way that I have shown you. So I am just kindergarten general AI. I haven't even went to primary school in general AI. And this is what could I achieve. Can you imagine what could I do if I could have third level education in general AI or get a master's degree in general AI? I'm not talking about super AI yet, but that's a look to our future and the vision that I have for any vascular unit. I thank the organization and the chairman and the society for the kind invitation to give this talk to you, and I'm happy to answer any of your queries. Thank you so much.
Well, Professor Sultan, thank you very much for a most inspiring presentation. Clearly, we are just scratching the surface of the potential of artificial intelligence and its application in the healthcare in general. I think I would like to open the floor for questions, and but before that, I have a comment and a question regarding the comments you made about the radiologists and their potentially dwindling role, and it relates also to the need of teachers. Do you think that their role is going to be abolished or transferred into more of a teachers, because someone ultimately need to teach the machine learning what's right and controls the input and make sure that the input that is teaching the machine is correct, and double checking on that so that you can get the appropriate identification of pathology, etc. So do you think their role is going to be shifted from doing the routine 2 seconds looking at the X-ray to monitoring the accuracy of the machine learning?
We have run all the scenarios, and we predict there is 3 specialists in medicine will disappear totally: general radiology, general pathology, and general internal medicine, internist. They will not exist. So currently now, if you have a CT scan or an MRI, a lot of companies now have already signed contracts to have it been done through software. You just send the DICOM images. It has specificity and sensitivity very close to 100%, better than any experienced radiology, far superior. And they pick other stuff that nobody else could pick. So this is for radiologists. For pathologists, I don't think they'll be able to count the cells as a machine. And I think that they're becoming redundant, because the retinal display of the new microscopes for the machines cannot, the human eye cannot match it, and they will be gone. They will be sitting at home doing nothing, because the machine is far superior, much more powerful. So they have to change their way of thinking. Internal medicine, everybody now asks Google, what's wrong with me, and get 10 differential diagnoses. However, the only way forward for a radiologist is to have intervention part under his belt in order to carry on. The pathologists, they have to be part of the management team. So if he is doing a reading, he has to design some oncological treatment. And for the general medicine, they have to be doing bronchoscopes or doing OGDs, because just looking for the patient to prescribe medication, it doesn't exist. It will never exist in the next 5 years.
I suspect dermatology would be another one. I mean, probably machine learning can easily detect a melanoma much better than any other dermatologist, probably, by just looking at the photography.
I don't see any dermatologists. Definitely, they are so scarce to the extent that nobody wants to do it anymore. I don't know. I haven't seen dermatologists for a long, long time.
Well, I would like to ask Professor Mas'ad to contribute and ask some questions. And please, to the audience, please send us your questions on the chat. I would greatly appreciate it, so that we can pass on your queries to Professor Sultan.
Dr. Sharif, thank you very much for your outstanding comprehensive lecture, which you are used to have this from a daring vascular and vascular surgeon like you. We are always proud of having you among us, and when you are talking, we always keep listening. I have a few comments about how these machines are working, and as assimilators, and how they can help in the interpretation of the data and optimize the human inputs, and they can even minimize the time to make use of our data. But in my concerns, what is the role of these old devices and the machines in the vascular real practice? Is it going to supplant the vascular surgeons, or it will streamline their jobs? Because I expected to have some thoughts, like having a chips that is being implanted inside the TVAR or the FIVAR that can reach the hemodynamics of the patient and give us some emission of the data that can be categorized over a nearby machine. And then we will have some concerns about the early failure or the early endoleak or whatever by giving 24 hours a day monitoring of our patients through such machines. So what we are at this step among the high tech which you are facing now?
Very good question and very difficult to answer, but we need to start, first of all, the current technology, putting a TVAR or an EVAR in the patient causes a lot of negative effect on the heart. So you have already treated the aneurysm, you have treated the aorta as if it's a redundant, you put a very stiff graft in it. So there's a back pressure on the heart, so the heart starting failing, and the patient died from congestive cardiac failure and myocardial ischemia, to which he doesn't have a coronary occlusion within 5 to 10 years. So the whole idea of putting a tube into the aorta is the problem. Now let's go back about monitoring. Monitoring devices are available everywhere. The problem is that why I going to look for a monitoring for a device that the device causing the problem? I think that what we need to start looking at the proteomics and genomics of the patient and try to adjust this on the molecular level before it arrives. Prevention is better than cure. So we know that a lot of patients that develop their aneurysm are because of, they have the gene, first of all, from their dad or their mom, and then they have high blood pressure. So let's get that gene and just try to prevent him from having high blood pressure. Or they're smoking, so we'll get him something that he can't smoke and have nicotine. The problem is that if he's stressed because a nagging boyfriend or a nagging girlfriend and she's annoying him all the time and getting his blood pressure up, he can't do anything except he has to move on. But there's a lot of environmental factors that we need to look at it. And we have to be on the preventive side rather than the treatment side. However, you already put the graft in this patient. So you have to manage him. You have, rather than you follow him with CT scan, you need to follow him with CT scan and an echo of the heart and troponin. Because he'll come to you, I have chest pain, I have an interscapular pain. Why you have that? Why have done so? The problem is that you have creating myocardial ischemia because the adaptive left ventricular hypertrophy. You know that if you were, I'm sure you were when you were young and driving these fast cars, they used to put this small pressure sensor inside the car. Now it's in the BMW and Mercedes come as a routine when you have a flat tire because they tell you exactly what's going on. There is some centers starting to put this inside the aorta, but the problem is that it doesn't last that long because it's in a very hostile environment and the cytokines attack it and it doesn't last that well to produce what they're looking for. So now they start building into the wire itself and try to take its electricity from the wave of, it's like taking the electricity from the wave of the water in the ocean. They try to take it from the movement of the blood inside it. But still, you know, it's not great to invest in this. I think that you have to get the money invested in different way of managing aneurysms and dissection rather than looking at what happened, because these guys, anyhow, they are at the end of the line. Within 5 to 10 years, they will be dead anyhow because of the cardiovascular problem, or you improved your life, they're going to die from malignancy. Because what we have seen, you do the aortic aneurysm, excellent. The patient will not die from the aortic aneurysm. He will die whether malignancy or cardiovascular or stroke. One of the three things will kill him. So that's the problem. And then COVID came in, and there's a lot of patients died above the age of 65 beyond your imagination. They just disappeared in the thin air. And this is make the society much more agile now. And there's a lot of fitter patients than before because that COVID have allowed just control alt delete of a lot of sick patients and a lot of patients in the nursing home. It's so sad to lose a member of the family, but that's what happened on the ground.
Okay, we have a question from the audience, which also applies to how do we go from here? How can a young surgeon, for example, make use of the general AI knowledge level, pattern recognition, in order to be able to improve or develop their level of care? And how can artificial intelligence help the budding surgeons improving their skills in things that are not common anymore, like open vascular surgery or open aortic repair and things of that nature.
Excellent. So the first step that he has to regroup and start arrange himself. Just start, first step, get a 6 Sigma in your department so that you understand what you're doing algorithmic wise. Write a surgical pathway for somebody coming with an aneurysm or with a carotid or with a peripheral vascular disease or with a mesenteric ischemia. Start analyzing your own data. That's the first step. Second step, and this goes parallel with it, start talking to the multinational. So for example, that Philips or GE have a fusion technology. That's artificial intelligence. And when they give it to you first time, it needs to be fine-tuned to your table and to your patients. So you have to start creating your ability to allow to analyze it. This is the first, very simple steps first. Then move forward, that there's a lot of companies available like Visai that you allow to put your DICOM images in it and it analyzes it for you and give you exactly the finding in no time at a cost of nothing. We just need to take the golden mine of the data from you in repair to do that for you. So you need to start somewhere and don't say that I have no money. What I've told you now doesn't require any money. The 6 Sigma could do it yourself. You're already operating in with a Philips or GE machine or Siemens. All of them have this technology, even on the C-arms. So you need to ask for it. Don't stay on it. And you have to stop looking at stuff that you don't need. Do what you need to do all the time and focus, focus, focus. A lot of people tell you that there's no way. A lot of people will close the door in your face. Open every door. Try to fight it because it's only you. And you need a guy who's so enthusiastic in your department to pull the department from its neck forward. Do not stay in the line. Staying in the line will not allow you to achieve anything whatsoever.
Okay, I think we have Dr. Martin in the group who wished to ask a question. So Dr. Martin, can you ask your question? Okay, maybe it doesn't look like he's able to do it. There's another question about, are there any current means of measuring aortic elasticity compliance that can be applicable to the manufacturing of the grafts or of the custom-made aortic grafts and endografts?
Definitely, you could do, first of all, that if the graft is in more than 6 months, you'll be able to 4D MRI to see exactly what's going on. But at the same time, you could measure the pulse wave velocity from the arms and from the femorals and see exactly what's going on over there. Computation imaging could allow this with fluid dynamics. And there's a lot of available software, but it requires a mega computer to analyze it and allow you to know exactly how much and where is the stress and what's the elasticity. The problem of the aorta is like you have a car, old car, and you're getting a piece from Fiat, a piece from BMW, a piece from Mercedes, a piece from Toyota, a piece from Ford. So part of the aorta is designed differently in different area. And that's why when they do a blanket stent for the whole aorta, they are not respecting the aorta as an organ. The aorta is an organ in its own and is the most important organ in the body. Without the aorta, you cannot function. And in fact, it's not recognized as an organ, which is crazy.
Professor Masad, you'd like to ask questions and take it from your end?
Actually, it's rather a comment about the emotional AI, because one of the audience is just saying is that we had enough of the humans, so please let the machines to do what they are good at.
It will happen whether you like it or dislike it. And it's happening currently. And the problem is that you could see that the minute they cross to the super intelligence, you can't control them. Now the machine is asking for a soul. You could see yourself. Remember, Google were frightened when their engineer said that, oh my God, they're developing emotion. They fired the guy because this was a military secret inside Google because he published the paper. So the problem is, can machine develop emotions? Yes, it's not emotion, it's a coupon. It's basically, they are learning so fast because they analyze more data than anybody. What it take you million years to achieve, they'll achieve it in less than 30 seconds. That's the whole idea. And they'll be able to think beyond. They're like a chess player. You are already planning 4 steps ahead. They have already planned 50 steps ahead.
Another question from the audience. You mentioned that the role of physicians will be strongly oriented towards values that are unique to humans, such as empathy and persuasion. Could you please possibly elaborate more on how this will manifest in a usual workday for a physician? Give us
Perfect. That's a very good question. So currently, your role as a professor of vascular surgery in your department is an oracle. You're the boss. You come in, you're the oracle, everything goes around you. In the new revolution, you will be a counselor. So there's somebody taking the decision, and you'll be coming in, breaking this decision to the patient, because you have no role of taking this decision. There's better people taking the decision than you. They're much more professional. They do not do mistakes. They do not go away from the norm, and they give you the best option. So suddenly your role have changed from a boss, an oracle, to a counselor. Then the empathy. There's a lot of things the machine cannot develop now because we don't know. But I think by time they'll have it, and then human will be redundant. We'll have nothing to do. But for the next, at least until I retire in the next 15, 20 years, I'll still have a job to do, and I'll be still able to decide for my patient, because things are moving so fast, but still we haven't met with the ability to apply it to every available area.
So how do we help our children, and how do we help our budding surgeons who are now graduating and looking at a 30-year and not at a 10, 15 years? You and I are safe because we still have things to do in 10, 15 years. But how about them? How do we prepare them for the future? What they should do? How do we give us some pearls here.
You already started in university. You already have this 7 months fellowship in AI. So this is the whole idea. Created the COMENDA, which is part physician, part engineer, and part statistician. That's all what we need, because you cannot, whatever you teach the student today, tomorrow is obsolete. It's changed. So it's crazy that you get them in for 5 or 7 years in the medical school. They're wasting their time. You just need to come in and just give them the basis, turn them exactly, and then gear them wherever they want to do. So what we need to change the way that medical schools are doing, and engineering schools and everything. He have to have create this new guy who can program, who could write codes, who could look at the algorithm, who could check and validate. At the same time, he will be able to look at the patient and have the empathy and be the counselor. So the COMENDA is the way forward. They have to be that. We have to change the mindset. What we have now is antiquated. It is old. It is dinosaurs, and it's gone. That's why I've shown you the area from Mr. Tom Cruise, when he told him that, look, you're gone, you're dinosaur. You are not part of the future. And then he stood up and took the F-18 manual and threw it in the bin. That's the problem. We're still having the textbook of Bailey and Love or Hamilton Bailey or whatever it is reading in it. But what are you going to do with it? Everything is available in front of you on your smartphone. You don't need to resuscitate any of that at all. We are just wasting their time. We need them to examine the patient to understand what's happening in an area that don't have the ability to get this stuff.
Well, I think this is a very provocative and insightful presentation. It's going to give us a lot of thinking, and we have a lot things to think about and do, actually, and reorganize and get ready. I want to make sure if any other questions from the audience, anyone, I mean, I'm sure we can still tap for questions, many more questions, but we're already more than an hour past the time. So let me see, Dr. Martin, can you try to pose your question or send it to me so I can pose it on your behalf?
Yeah, Jamal, can you hear me?
Yeah, we hear you now. Excellent, Martin.
Yeah, it's amazing to be with you and to see you. Sharif, I have been waiting for this presentation for a week, and I can tell you I'm not disappointed at all. It's lovely. It's just, as Jamal put it, it's been just, you know, too huge, and it's so many issues. That's why I love having a cup of tea with you, because in person it's much easier to discuss all these topics, you know. As you, I feel the same. You know, we are obliged to our students and our trainees to go this way. And I've had this talk with the dean of RCSI here in Bahrain. But unfortunately, as I'm sure you feel the same, the change in medicine and medical practice and the change we are facing is much faster than rigid educational system can really swallow. Okay, so this was the first you know, issue I wanted to tackle, that to change the educational system in a way the technology is changing, it's impossible. Okay, so this is, and that's the problem, because we have to adapt the curriculum to the changes we are facing, and you amazingly pointed out all these in your presentation. So we obviously cannot go through all the topics you opened, but this is the biggest one, like how we can adapt the curriculum of the medical students to be able to deal with all these changes. That's my biggest issue here. And this is the remark, and the question to you is, you know, because on the individual basis, I've already changed my own way of teaching medical students. So we are starting the very first lecture talking about the technologies and about the data and about like all the changes we are facing. But the other issue is all the legal process dealing with data itself, because as you put it very clearly, this is one of the biggest problems. It's going to be an issue because the companies like Google or Meta, they already you know, collect the huge amount of data, and it's going to be a medical data, and it's not regulated. Yeah, so it's I want to ask you if you have thoughts about this, how to regulate the data, who's supposed to own the data, the medical data, which they already collecting, you know, the big companies. It's going to be a big deal of problems.
Martin, you have two major questions. The first question that you're asking is about medical education. It's exactly like the F18 textbook. It needs to be thrown away, Control-Alt-Delete, and start brand new. Whatever you have done now is useless, is obsolete, is gone. And whoever going to tell you anything apart from that, they're kidding you and they're lying at you, and they don't give you the future. The future is completely different than what we have now. And if we need to have good people, we need to change everything, and we need the strong guys with vision to come in and do this. We need to use augmented reality, and this virtual augmented reality is very important to teach them. And at the same time, we need to get guys who will be able to do a lot of tasks. That's part of the question. The second part of you to answer it is just, it's impossible to understand how this data could be manipulated. The data in your department is gold, is in fact, is much more expensive than gold, but it's how much price you're going to put in it and how you're going to packet it in order to be attractive. Because what's happening that the company will come, it'll buy your data and give you the AI know-how in order to build your system. This is how it works. So because the more data they get, the more accuracy they have in their precision medicine. And that's all what they're looking for, whether oncology, diagnostic, orthopedic, vascular, cardiovascular, whatever it is. So data is crucial. It have to be anonymized. And now with the data protection in Europe is a nightmare. And it depends upon how you'll be able to manipulate the situation. But remember, the only thing that you could have it in your hand that worth billions is the data of the patient, because they need all these data points in order to improve their algorithms. And this is the only paper in your hand that you're going to negotiate with this. Definitely, there will be a lot of artificial intelligence companies listening to this talk, and they could shoot me now because I'm just burning the car, but it's the only way for you to have things happening without investing billions. They already invested through VCs, so you need to use it, and it's a catch-22. But the regulation in Europe have becoming so suffocated to the extent that you cannot transfer a CD between two hospitals. In the United States, is less severe than Europe. In the Middle East, I don't know about the regulation, but I don't think it different than Europe. I don't know. I can't judge on it. But remember, the data of your patient is the gold in your hand.
Yeah, I totally agree. We are opening the new workshops about like peripheral and aortic, treatment. But I believe much more important workshop, the next we have to organize, maybe on this platform, it should be the workshop about the topics you have opened in this very precious talk. Thank you very much,
Martin. Great, thanks so much. Great to hear your voice.
Thank you, Martin. I'm gonna finish with the last question we have here, just for the sake of time. How about the state-of-art regenerative therapies to repair or reverse atherosclerotic aortic degeneration or others? You mentioned things about stem cells and the $500 million wasted. Is this going to be another wasted effort, or there are things in the pipelines?
Okay, so stem cells doesn't work in peripheral vascular disease. Let's agree on this.
Yes, we know that.
Okay, so this is gone. Now, there is a lot of research about trying to use the stem cell in order to modulate the problem into the aorta, whether for dissection or aneurysm.
That's the question.
But still, it's in infancy. They're trying to infuse the polypotent cells, but the problem is a high flow state. And in order to stay or do anything, you need to do some sort of a gene manipulation, because without this, it will never work. Still in infancy. It will take another 5 years to get something going on, but you'll never say no about anything until you're going to see what's happening. But it might be another 5 billion thrown in the bin before we're going to say, oh my God, I told you so.
Well, Professor Sultan, I have to tell you, I've been receiving a lot of messages on my WhatsApp and on the chats commending us on this, on your beautiful and inspiring presentation. I want to thank you very much for all the efforts put in sharing it and in putting some clinical applications to it in all the aspects of it. I also want to thank my co-moderator, Professor Masad Suleiman, for his contributions, and all the team in Pavis. Thank you very much. And to the audience, we are delighted that you are with us, and hopefully we will continue to provide you with valuable educational material and valuable educational programs on a monthly basis. Thanks again, and hope to see you one day in Lebanon. I will follow up on that, Professor Sultan.
Thanks so much for the opportunity.
Thank you. Thank you, Dr. Sharif.
Thank you very much, Doctor.
So,
thank you very much, Professor.
The group, the IT group, I think you did a wonderful job. I think it's been excellent. We really thank you for everything. You've done wonderful. Thank you again.
Thank you. We would like to express our appreciation for this valuable webinar, and this treasure we gained will be shared on Facebook, will be shared on YouTube, for all vascular surgeons to take the best benefit of it. So will be shared, and all links will be shared. Also, we will have PAV's monthly scientific activities in the next month and next month till our great first meeting will be at Luxor. Till November, we will have a lot of scientific treasures like this that will be shared every month. Thank you very much, and we were very happy to meet all those great professors. Thank you very much.
يعطيكم الف عافيه. Thank you very much. يعطيك الف عافيه. We're really thankful. يلا
Thank you.
تصبحوا على خير. Good evening.
شكرا دكتور، شكرا.
شكرا.
شكرا.